right, all yours.
Okay. So I'm delighted to talk about this because I think we have a wonderful population to do research on, and actually we need to learn from this population because MAT is not new in terms of methadone. However, so there are a lot of things going on, and we can learn from our patients every day. So I'm going to I separate this into two different presentations. The first one, we're going to talk about tele-MAT program study. And the second one, I'm going to talk about sleep, because sleep is a very important thing. It's almost like the fifth vital sign in our mental status. So basically, we talk. A lot of times we discuss with patients, ask about sleep problems, complain about sleep problems. So the second part of this a different presentation. I'll do that in January. Is that right? Mm-hmm. So we'll talk about another study. Actually, we did a very good study in sleep in MAT patients. So I'll give you some definitely new knowledge on that. So let's just how can I navigate? So just
I should just be able to click on just up on the
okay. So first I disclose that I have nothing to disclose. That's kind of interesting. So the purpose of this presentation is to give a brief report on two pilot studies, because they're small studies funded by our department, luckily, and conducted in cold clinic population. We have 500 patients. Actually, in the past more than 10 years, 16 years, we have treated more than about 3,000 patients. So a lot of things we can do. Share some research experience in cold population, and also most importantly, to use these two presentations to encourage some research activities from all of you guys. So hopefully we can just collaborate with each other down the road. We can just, find some new knowledge from this. So this is from a Nobel Prize winner, Albert Szent-Györgyi, I think, Hungarian biochemist. So this is a quote from him. Research is to see what everybody else has seen and to think what nobody else has thought. So I think it's I use this here because I think that there are a lot of things there are a lot of MAT programs all over the country, all over the world. But there are a lot of things we have learned from our program. And the question is, how we can disseminate the knowledge, or how can we make it an evidence-based treatment program for everybody to learn. So that's, I guess that's the reason why we are here, right? So this is a tele-MAT study. This study was published in Journal of Addiction Medicine in 2017. So the title is Treatment Outcome Comparison Between Telepsychiatry and a Face-to-Face Buprenorphine MAT for Opioid Use Disorder, a 2-year retrospective data analysis. So this is it is a teamwork. So you see a lot of authors over there. I happen to be the one who wrote this to organize this. So, but I have to give credits to everybody. So I'll acknowledge that at the end. So the title of this, you can see that it's a treatment outcome comparison. Because the question is, what do we do here for patients, right? How can we measure the treatment outcome for opioid addiction? So we give patients buprenorphine. Rarely we see patients relapse on heroin or other opioids. So a lot of studies mainly are done this way. So they measure the opioid-free days, which is a very, very important parameter for us to see, right? Because we want to see. But of course, frankly speaking, when we talk about addiction as a primary chronic disease of brain reward circuitry. So we want to see patients really improve their wellness, right? We're talking about the crime rate, talking about employment rate, talking about the relationship, the marriage, right? Getting kids back. Those things are real outcomes. But how can we do that kind of research? We don't. It's very hard, right? When you guys see patients from your sites, then those things are what we look for every day in our daily practice. But here in this research, I just did a retrospective chart review. So we went back to review the records for 2 years, from 2013 to 2014. So we look at the different things to measure the outcome. I can tell you a little bit more here. Okay, so first, we talk about telepsychiatry. It's a promising way to deliver mental health care remotely. And it's a particularly important and attractive option for rural patients, because those patients, because of transportation problem, right, they cannot just come to your site to see you. And it's particularly important in mental health care because, luckily, we don't need to do physical exam all the time. We don't need to touch the patient. But face-to-face interaction is important. I have to say that. So how important is it in our MAT model? So we don't know, right? So telepsychiatry is important, and telepsychiatry has been pretty popular in this state as well. So we have one of the largest telepsychiatry centers in the United States, actually. So since 2009 until today, we have serviced more than 50,000 patients. We're talking about more than 50,000 cases. So it's a lot of, it's a lot of patients, right? So here at Chestnut Ridge, so doctors and psychotherapists, nursing staff, we sit at Chestnut Ridge Center, seeing patients remotely from, I think they have like 13 different counties, like 37 sites, like, a lot of sites are covered. So basically, telepsychiatrists just use audio-video technology, right? You see patients remotely. And so the code tele-MAT model. So what is it? So the telepsychiatry program follows the same model. So basically, we still do the code, exactly same thing, same case management, same structure. We see them weekly, bi-weekly, and monthly. That's pretty much the same. The only difference is the psychiatrist delivers addiction assessment and care through video conferencing tools. So basically, that's one psychiatrist we're talking about during this research time, okay, talking about the research period. So one psychiatrist sits in his office at Chestnut Ridge Center, saw patients remotely 200 miles away in very southern West Virginia counties, Mercer and McDowell County. Okay, now we're not seeing those patients from their homes. So first, those patients came to the local mental health center, Southern Highlands. So the patients came to the mental health center, just do exactly the same thing we're doing, in your center and the Chestnut Ridge, same thing. They still do psychotherapy 1 hour after half an hour telepsychiatry with one psychiatrist locating in Morgantown. So, but otherwise, everything else, we follow the exact same model, okay. So the study aims, the first thing we want to do is to compare the face-to-face group and telepsychiatry group. So face-to-face, the doctor sees patients here in Morgantown office. So we select a group of patients. Then we select those patients from Mercer and McDowell counties. They go to Southern Highlands to see same doctor remotely for that half an hour. Of course, they see different therapists, but we're talking about the structure of the program is same. So basically, the basic structure, the basic therapies they receive is still addiction focused, right? Yeah, there's no big difference. So we look at 3 outcomes. So the first is retention rate in weekly and bi-weekly group. So we want to see how many patients we can retain. How many patients, what percentage of patients can stay in the program after 30 days, we're talking about in weekly group, 90 days, and bi-weekly groups. And also we want to see average time to get to the first 30 and 90 consecutive days. First consecutive day sobriety. We're talking about if we want in these 2 groups, we want to find out, how many days does it take for patient to get to 30 days or 90 days. Remember, we reset the clock all the time if they report relapse on any drugs or controlled substance, right? So if they use alcohol, if they use opioids, if they use cocaine, if they use marijuana, we count that as a relapse. So we reset the clock. So we want to see, on average, how many days does it take for a patient to get to 30 or 90 days. Then we also look at the third outcome measurement, which is additional substance use rates. So we check, basically we're talking about additional, not in addition to Suboxone, which they get a prescription. If they use either one drug, two drugs, or three drugs, 1 to 3 drugs, or 1 to 2 drugs, or 3 to 5 drugs, including alcohol. So we count them, then we group them, then we try to figure out, whether the rates of relapse are same or different. So this is study design. The study design is like, we review the patients from January 1st, 2013 until the end of 2014. So total is 2 years. So of course, all those co-patients, we have 2 groups. 54 patients were seen in Morgantown, face-to-face. 47 patients were seen from 2 different counties, Mercer and McDowell counties, remotely through the video and audio conference tool. The MAT services offered same structure as CODE, right? This is our CODE program. Structure, goals, and attendance policy were exactly same, regardless of group therapy location. The group therapy location is different. Of course, they also delivered by different therapists.
And that part is in person.
Yes, that part is in person. The only difference is the medical group. Yes. So the demographics were collected in order to compare the participants' characteristics. So we want to make sure they're comparable. So very briefly talk about this slide. So you can see in the telepsychiatry group, tele-MAT group, we have 47 patients. Face-to-face, we have 59 patients. So you see the age is about 30 to 45. For both groups, it's kind of very comparable, right? Actually, looking backwards, I mean, I'm doing a lot of more research and studies now, looking at the 10-year CODE data. Actually, this demographic information pretty much applies to the whole patient population we're seeing. So gender, you can see, is about like same. We have same percentage of female and males, and females a little bit more in these 2 groups. We have majority patients are kind of white, right? 96, 94%, they're pretty much same. The education is a little bit different here, and so we're talking about but more people with higher education, higher than high school education in face-to-face group. But it's just 2 small groups, right? But also employment rate, also a little bit different. That can, that's kind of, I think it's kind of consistent with education as well. You can see the second group, face-to-face, we have 20% people employed. And well, you have about half of patients more than high school education. Some of them, like here, I counted it like a trade school as like after high school, so some college education. Okay. So other comorbid psychiatric diagnosis, it's kind of interesting, right? About 70% of our patients have a comorbid psychiatric illness. So this is actually true for this population. Finally, most of people received, so they're not new patients in 2013 and 2014. They might have had treatment somewhere else, or they might have had methadone treatment in the past. So this is the graph shows patients, basically, how many patients reached 90 days and how many patients relapsed. But I think it's too complicated to talk about here. So let me talk about these 3 tables. I think let's focus on this. So this is a comparison of time to 30 and 90 day abstinence. So just look at the numbers in red. So I highlighted here for you to see. So the first row is time to 30 days. The second row is time to 90 days. So the red numbers are mean, okay, mean for the whole group, average. So for the telepsychiatry group, the mean time to get to 30 days is 35 days. And face-to-face is 42 days. And also the mean time to get to 90 days is 106 for telepsychiatry group and 112 for face-to-face group. Interestingly, if you see those numbers in green, actually, the maximum time for people to get to 30 days is 70 days, if they can make to 30 days. Now, remember, there are people who never made to 30 days, right? Those people we cannot count here. So that means it takes people about 30 to 70 days to get to 30 days in telepsychiatry group. It takes about 30 to 112 days to get to 30 days in face-to-face. That's interesting. Because face-to-face, it takes longer time. I don't know why, but actually, statistically, there's no big difference because 0.09 is not significant. And takes about 90 to 194 days to get to 90 days. That's about right. And takes about 90 to 236 days to get to 90 days. So it takes a while. So if you look at your group, I would say this number probably is representative, right? Because a lot of people, you need, if that person can stay in the program for 6 months, we're talking about 180 days, that person most likely will make to 90 days. So 6 months, I mean, double the time, it's very, on average, I would say, that person can make to 90 days, if that person can stay. So this is a 90-day retention rate. So next, I want to find out how many people will stay in our program. So after 90, we're talking about after 90 days. There are only two numbers you need to look at. The first one is 51%. The second one is 49%. Statistically, these two numbers are kind of pretty much the same. So that means we lose about 50% of patients in our weekly group. I'm not sure whether that is the case for your individual clinic. So for us, basically 50%. This is pretty much consistent with the national data. The national data, most of the articles report like between, I would say, 40 to 70%. But remember, we have a very highly structured program, and we have strict rules, right? And we reset the clock all the time. So given a very strict program and treatment policy, so our retention rates are pretty good. So we keep half of patients. That's really good. Of course, we're talking about our samples are pretty small, right? So then the last one is comparison of 90-day and 365-day retention rates between telepsychiatry and a face-to-face group in patients enrolled before January 1st, 2014. Why I put enrolled before January 1st, 2014 is because in order for you to find out whether that person can stay for 365 days, then for those people who enrolled in 2014, you don't even have enough time to count them in, right? So here the sample size is smaller. You can see the total is like 24 for the telepsychiatry group and 31 for face-to-face group. Okay, so how many people who stayed? I'm sorry.
Okay. There you go.
Yeah, so how many people stayed more than 365 days? Actually, we have about 41.7% for telepsychiatry group and 35.5% for face-to-face group. So you see, again, we lose about 50% of patients in this, for this year for people who enrolled in 2013, right? So if we look at only half of our samples, it's still pretty consistent. We only keep about 50% patients. Then again, we will continue to lose about 10 to 20% of patients in the next 9 months. Then finally, we have about 40% of patients stay in our programs. And interestingly, for those people, if we calculate how many people, if they stayed for more than 365 days, if they made to the biweekly group, then our retention rates jump to 65 to 85%. So that means people who stay longer, they tend to stay. they tend to comply with treatment. So once they made to 365 days, so once they made to monthly group, so it's more likely they will stay in the program, they will continue to do better. So this is very encouraging. So that's why I always tell my patients, I said, if you make to 90 days, the chance of staying longer is better, then the chance of you getting better is better, right? No matter what, this 90 days, 90 seems to be a magic number. But then again, 365 days, you know, per our calculation, per our study, and the chance of continuing to be better is also very high. So that's very encouraging, I think.
Mm-hmm.
So,
definitely.
Right? So the conclusion is we did not find any significant statistical difference between telepsychiatry buprenorphine MAT through video conference, talking about and face-to-face MAT treatment. So basically in our code model, if we deliver telepsychiatry, if we deliver this medical group service through telepsychiatry, and it's pretty much the same. So maybe it says something about our treatment.
Mm-hmm.
I think the treatment structure and also therapy sessions are very important.
Mm-hmm.
Maybe psychiatrists just take credit from this. I think it's a therapist. I think a psychotherapist should be complimented for sure.
You always give credit to the whole structure to all the staff when you're in co-group. I appreciate it.
Okay. So anyways, so we're talking about 3 treatment outcomes. We did not have a chance to look at all other outcomes. Like I said, those outcomes are more important for us to look at. So at least for additional substance use, I did not put a diagram on the table here, but basically there's no difference at all between the 2 groups. An average time to 30 to 90 days of abstinence also same for the 2 groups, and treatment retention rates also is encouraging and also pretty much same between these 2 groups. So I want to acknowledge here, so Dr. Sullivan is my mentor. He created the program, designed the program, and taught us how to do it. And so also in this study specifically, he gave me the idea and encouraged me to continue. So the department support, because we got money from the department, which we are very thankful. And also we're grateful that people, you know, from Southern Highlands and our telepsychiatry group help us collect the data. So I also had a lot of co-authors, of course, and I want to give credits to them. So yes, anybody has any question? We still have a couple of minutes to answer. Yeah.
Thank you so much.
That was great.
That was wonderful.
Mm-hmm.
All right, guys. Any questions? Comments?
I mean, that was very encouraging to see that the retention rates are very similar, right? It makes me wonder, boy, what can we do to expand this in terms of medication groups and treatment groups? So for the telepsych, for the therapy groups, were they also teletherapy groups?
No, they're face-to-face therapy groups.
Face-to-face therapy groups.
Yeah.
Okay. Do you all have any telepsych therapy groups?
Yeah. Well, they have. What is that? What's the question?
Were you asking, do we do any telepsych?
Yeah.
Groups. There is I don't know what grade it is. I know Emily Chilko and Bonnie Strayer participate. They do like an IOP, so it's not the COAT format, but I know they do group therapy via tele, and I'm sure they're collecting data for that.
I didn't know that, so yeah. But we have
a newish end.
Okay, Dr. Law might know more about it.
Yeah. Okay. Good job.
All right, guys. Any other questions? Perfect. Thank you, Dr.
so much
Zhang.
again.
If you guys have any questions, you guys can email them, and I'll make sure Dr. Zhang gets them. All right. I did want to make a quick announcement. If you're not talking, make sure you're muted, just because sometimes we get a little bit of that background feedback. Just wanted to say that. It's down there in the lower left corner if you're on the screen, you know. All right, and then Lively Healthcare. Are you guys ready for your case? If I were to share it?
Yep, I think we're ready.
Okay, excellent. All right. All right, whenever you're ready.
Okay, so I'll just sum this up so we can spend more time talking than having me talk most of the time. So we have a 29-year-old white female. She came into the practice about 3 months ago. She came from another non-WVU affiliated clinic within West Virginia where she was on Suboxone. And so she transferred to us with a recorded sobriety date of April 27th of 2018. She's down to an 8 milligram dose of Suboxone from the original 12 that she came in on. And that's based on her request to taper off the medication. She's not had any positive urinalysis screens for opiates, which were her previous drug of abuse. But she has, at the initial intake, she was testing positive for marijuana. And at that time indicated that her prior clinic was allowing her to use the CBD vape. So we instructed her that our clinic rules did not allow for that and that she would need to stop using CBD. And we watched as she tapered down in her THC levels, and she actually was successful at stopping, and she was testing negative for THC for a good while, probably about 2 months until just recently. She tested positive recently following a gallbladder removal surgery. For 1 week leading up to the surgery, she was switched over to Subutex. Following the surgery, she was supposed to continue Subutex plus take Tramadol for a 3-day period of time, and then we were going to move her back over to Suboxone at that time. When she reported back to clinic, she was at about 513 days sober. And when she reported back, she indicated that she had used marijuana during her recovery because she was not taking the Subutex or the Tramadol as prescribed. She said that she was afraid to take the Tramadol based on her previous addiction to opiates, and I guess her previous experience with marijuana and pain control told her that it would be appropriate for her to use it. At no point did she call the clinic and express to us that she was struggling with pain, or check in with her surgeon for that matter about her pain, or to talk to us about any other alternatives to using the marijuana. She just basically took it upon herself to make that decision. And so when she reported back, we had a rather robust discussion amongst the team about how to consider that, whether it would be considered a relapse or not. Ultimately, we made the decision that it would be considered a relapse based on her failure to reach out for assistance prior to her decision to use marijuana, and the fact that she made an ultimate decision that was against rules within the clinic. And so that pushed her back from 513 days sober to 0 days, and she's starting over again now. And she went from an advanced level where she was only coming once a month to a beginner level, so now she's expected to come once a week. Obviously, she's frustrated about that whole concept and process. We did express to her that, you know, you can count your recovery days however you feel that you need to count them. If you feel that your marijuana use was not a relapse, then you certainly can continue counting past the 513 days or beyond those. But within the clinic, we would have to count her days starting back to 0 from the day that she used the marijuana. And so we wanted to get your all's take on that situation and see how your clinics would count her sobriety time based on that use of marijuana, to determine whether or not we need to rethink our decision and how we take care of things in the future.
Oh, great.
Well, first of all, thank you so much for presenting that case. I think more and more we're just going to see CBD and people self-medicating with marijuana popping up more and more. So I think it's fantastic that you shared that. And also, you know, the fact that she was honest when she came to you about her marijuana use, I think that's a good sign. She felt comfortable to be able to tell you what she had been doing recently. So I think that's great. I think for us, there's a couple of things we would have done differently, and Dr. Zanger, Tony can add to this also. When she came in for the other clinic, we would have most likely started her days at, if she had said she just vaped CBD 2 days ago, we would have started her days then, regardless of how the previous clinic was doing it. You know, part of it, we want to help change their behaviors, but then also their thinking behind that. So we would have started that out a little differently. Not that it's bad that you did it that way. That's just one way we would have done that differently.
Right.
Do you want to speak about the one?
Yeah. So first, we really appreciate this this patient being so honest. She, you know, she told us what she used. Right. This is very important. So usually, even if we reset their clock, doesn't mean we push them back to their starting point for the treatment process. So we have, frankly speaking, in our bi-monthly group, even though we're talking about people who have been sober for more than 3 years. So if we recognize, if we appreciate relapse is, I mean, addiction first is an illness. It's a primary chronic illness. The second is, you know, relapse is part of the course of addiction. So what we do usually is like we, you know, we tell them, yes, so we do not want you to use marijuana, and we do this is because this is abstinence-based program, and we do consider that as a relapse. We reset your clock. However, we appreciate your honesty, and we appreciate your telling us and continuing to work with us. So we will continue to see her in the same, talking about whatever, you know, frequency, monthly or by, you know, bi-weekly, whatever. So we would not change her back to weekly first. The second is, if she lied, let's say she was not honest, if we caught her in urine drug screen she used, then still of course we reset her clock, but we may just you know, send her back to weekly first. But we learn from our past. We accumulate. Luckily, we accumulated, you know, some experience with this. So even if we send her back to weekly, but we have an AP code called Advanced Probationary Code Clinic. I don't really like the name, but again, so basically that person is being sent to high level of care. However, this we still recognize her recovery. We reset the clock, but she had good recovery in the past. So that means, yes, so she can come back probably in 4 weeks, 5 weeks, whatever. So if you have been seeing her every month, because she has been how many days? 500 over 365 days. She's already in monthly clinic. So you see her probably only weekly for if she lied, if she was dishonest about her use. I would see her weekly for 4 weeks, then see her bi-weekly for probably a couple of times, then just bump her back to monthly group. That's what we most likely we will do here in Morgantown. Another thing is like I would definitely tell her we appreciate her honesty, and we really, you know, think this is very important. This is the number one important thing in your addiction treatment. So I guess then I would like to, you know, ask her more about the reason why she reused. Is for pain control. Did that really help you with your pain control? Right? All different kinds of things I think you can try to explore. Another thing is like here, I mean, a lot of more people are using CBD. Of course, we don't want people to use that, but CBD does not have THC theoretically speaking, but it's not FDA regulated. So there's no way. So the way I communicate with my patients is basically I tell them, well, you know, I cannot stop you from CBD because it's over the counter, it's kind of legal thing. However, I'm not sure, first, I'm not sure whether it's gonna help you or not, because it's not FDA regulated. There's no, you know, formal clinical randomized clinical trials showing the efficacy of this kind of product. The most important thing is we check your urine all the time. And a lot of times, because the CBD oil is not pure, and a lot of times your urine will be positive for THC. And there's no way for us to tell whether you used or not used. And how would you prefer us to monitor? So that's the thing, right? Because you want to, you know, you're treating diabetes, you're getting diabetes treatment, you want me to check your blood sugar. So same thing, you're having addiction problem, you want to get better, then I have to monitor your urine. So that's the only way. But if this CBD use is going to interfere with our monitoring, and it's going to basically, it's not going to work well. So
yeah,
is that right?
Yeah, that's
Yeah,
I agree.
Have anything to? Yeah.
I liked what you said about you know, you talked with her about at the end of the day, you're going to respect whatever days she counts for her own personal recovery if she's working with a sponsor or not. And so that's a great way to kind of sidestep any kind of conflict of, like, at the end of the day, you're going to do what's best for you and your recovery outside of here, and we're going to respect and support that. Within the confines of our clinic, these are our rules, and we're going to ask you to respect, you know, the policies and the structure that we have. So that's how because patients are often bringing up CBD and what about when pot's legal and this and that, and so that's a way to not get into this, like, no, you have to agree with me that pot's terrible. It's more just like that, like, that's going to be your own journey, and I get it, and this is how we do things here.
Can I ask you guys a question? What was your prospective plan for her? You brought her back to weekly. Did you intend to keep her weekly until she had 90 days of sustained sobriety and then bump her up to bi-weekly again? Or what were your thoughts on that? That's what you plan to do?
Yeah, I guess in our minds, when you set their clock, we reset everything. But just because that's what we said, I'm not opposed to us going back and saying to her, this is going to be for a 28-day period, and then pending, you know, your success at that, then we will evaluate doing every 2 weeks, and then we'll evaluate 28 days later to, yeah, I mean, I'm fine with backtracking. I mean, our patients we've been really open about the newness of our program, and they've been really, I think, respectful of the fact that we're learning as we go, and we're kind of learning together. So I don't think we have an issue at all with us. Okay, we've talked to other clinicians, and we're going to rearrange our original thinking.
I bet that they are so grateful of how open and honest you are about that, and I bet that helps them appreciate you even more, that you're trying to figure all this out just for them and their health. I think that's so cool.
I do feel like we have a really honest group of patients. I hope it's because of what we're doing, but they seem to be really open about whatever's going on with them. They don't seem to have a lot of fear relaying information and being pretty open with us about what's happening.
Yeah, that's the environment that you've created for them. That's why they feel comfortable to not be scared, to be honest with you and not be judged about it. So that's great.
It's essential to the treatment. I think most patients, even they relapse, they come back, they got kicked out before in the past. They know we're doing a good thing for them. We're setting a treatment structure for them. And that's the only thing that could work. So I think, yes, a patient knows. Patient really knows what could work.
Yeah.
One thing I was going to add is that surgery is often a trigger for patients who have substance use disorders. And so it helps to not only treat the pain adequately with the appropriate treatment like frequent Subutex or Suboxone, but also to help them prepare for the negative emotion and how to deal with it in healthy ways.
Mm-hmm. Yeah, absolutely.
100%. Yes. So a lot of patients may know, because if it is elective surgery, then it's better for us. It gives a chance to provide a patient education before the surgery, before and after surgery, so we can work closely with the surgical team and try to manage pain, to have better pain management. I have had patients with neck surgery, C-section, tooth extraction, all different kinds of surgeries, and never really had any problem with with pain management, so pain control. So I think I have confidence that buprenorphine is with additional talking about NSAIDs and other medications, non-opioid pain control, pain management, then we can reassure patients and we can provide education and try to do early intervention. I totally agree with Dr. Hirschler, yes. And mood and anxiety change during and after surgery and need to be paid attention to.
I want to make sure we get some comments out from everybody else. Do you guys have, Dr. Bo, I thought you might have a comment or a question.
Oh, I was just gonna bring up that her concern that possibly tramadol wasn't gonna work. That's pretty valid for some people. Even when you use the NSAIDs and you get them prepared emotionally, they do have pain that is not taken care of by opioids. And maybe in our group settings, that's something we should bring up in our medical groups for those who don't. That hey, when you guys have surgery, some things to expect is this, and we should know about it ahead of time and just prepare you for it. Because some people do need the additional medications, and tramadol is not really is not as well for us. Our experience has been if you need an additional narcotic, it's better to use oxy or even Dilaudid as opposed to tramadol when NSAIDs don't work. So, but it's something to talk about. Otherwise, some patients don't feel comfortable and they feel afraid. So it's a good thing to bring them up.
Thank you. That's awesome. Any other questions, comments?
Yes, this is Dr. Morrison. I have a clarification request.
Sure.
I've recently started calling this thing you do where you reset a person from phase 3 back to phase 1 with a recurrence of use, and then move them back to phase 3 in like a month or two. I call that the acceleration plan, which it's kind of new to me, and I really messed up applying it recently, and I want to try to mimic the way it's done there at WVU. So I had a couple of people, and one was honest and one was dishonest. They end up in the application, it wasn't that dissimilar of what happened with how I let them accelerate back when they maintained their sobriety for a couple months after a late relapse. And so the person who was honest felt cheated, and so I'm curious how you all avoid situations like that.
Oh, good question. Sometimes they are a little individualized, but typically what we do, so if somebody in a monthly group is having a whole lot of relapses, kind of group after group, and the treatment team realizes that they need really a higher level of care, then we will make the decision to bring them back to the previous phase. So they would go back to the biweekly group. And most likely they would be in that biweekly group until they had a year of sobriety, and then they'd move on to the monthly group. If they were dishonest about their use, they would go to AP coat, and be in that format for a little bit, and then they would move back to the biweekly group. So there's sort of a slight difference between the two, one being somebody that was honest and one being not honest, but that makes sense. I could see how the person who was honest thinking like, well, it's similar to what the other person had. How did they respond to that in the group setting or with the other patients?
They didn't make a big deal out of it in the group setting, but in their individual counseling, they expressed frustration that they weren't feeling like they were being treated fairly. The problem was actually in the person who was dishonest. I should have put them to AP MAT, but at the time, and that's why I'm at home today, I didn't have, I'm trying to shut down my IOP operations because I don't have good coverage over the holidays. I have a trouble. In fact, I'm off on most of the Mondays and Fridays, and I don't have any coverage. And so to see people outside of standard times, I was trying to avoid having a lot of folks like that because I have to teleconference in on all of those on my off days.
Sure.
So that was really it's really a challenge for us smaller, more rural places when we need to take time off to be able to administer IOP.
Mhm.
Yeah, I can't imagine how difficult that is.
Yes, and whatever we're using here sometimes may not be applicable to small settings like yours. I think another thing I want to mention here, we do have one way to deal with like frequent relapse. Sometimes we have this, we call it a 30-day relapse, used to be called 30-day relapse dismissal plan. Now we changed that to 30-day relapse high level of care referral plan. So basically, so what we do is like if somebody's in bi-weekly group or monthly group, that person has already had good sobriety in the past. So, and that person now has been struggling. So what are you gonna do? So the question is, you know, then we give them a chance, right? We have to respect their honesty. In the meantime, we highly appreciate their continuing to work with us. So what we do is we tell them, how about this way? In the next 4 weeks, we'll continue to see you same way. However, we're gonna check your urine very randomly, frequently. If you're not allowed to use, you're not allowed to have one more positive urine drug screen. If you do, then we need to see you more often. So if it's a weekly group, but usually it happens in weekly and bi-weekly group, right? So if it happens in weekly group, then we just, you know, that works very well. A lot of people will stay 30 days, exactly 30 days. Then after 30 days, they were reused. So you can see how addiction, you know, can affect our brain. So, but anyways, so it works a lot, very well.
A lot of them will say over and over, like, I needed you to put me on that 30-day plan in order to get past that 30-day hump. And a lot of them will say, I thought about using, but I didn't want to come in and tell you because I knew you'd bump me back to the weekly group and I didn't want to do that.
So they will volunteer. Once they know that exists, I'm pretty sure they will volunteer for that. Yeah, right? Because a lot of times we have people volunteering for this kind of contract. Yeah. I hope that helps.
Any other questions, thoughts? To Lively Healthcare, did we answer every question you needed? Do you have any other questions or?
No, I think we're good. Just to clarify though, real quick, the relapse was actually on marijuana, not CBD. So she was using CBD when she came in, but during the surgery, the recovery from surgery, that was actual marijuana that she obtained illegally.
Gotcha.
So, but thank you, yes.
Yeah.
Thank you.
Thank you so much for the case. Yeah, absolutely.
I would like to make one point. You know, we tried to have a plan to address her pain using increased Suboxone, but the surgeon, you know, I guess he was a pharmacist before and, you know, decided she needed to go on Subutex and the Tramadol. So he kind of overridden us on that. But then her friend called us from the hospital and we told her, you know, how we wanted to address the pain, and instead of calling us back, she decided to go ahead and use the marijuana. So it's kind of addictive thinking, you know, in my opinion, all along.
But a great point. If everybody on the team, like you guys as your own treatment team, we're all on the same appropriate page, but if the other providers they're working with aren't, it's a great example of how that can put a potential little wedge in there.
Yeah.
I guess it speaks to the kind of lack of literature about how to handle this sort of thing. You know, if there was kind of well-established protocols, then there would be less disagreement between providers.
Yeah. Yeah, good point.
Well, awesome, guys. Anything else? We have about 5 minutes left.
Well, I'd like to ask an unrelated question, if we have the moment. It's about Suboxone allergy. I suspect in one of my patients with Medicaid. and it's very severe leg swelling with no other reason in a young lady. And so I'm just curious how you guys are dealing with that. Are you going to Subutex, Zubsolv, Bonneville? What's the strategy that works?
I'm looking at you.
I had the same. I actually had the same problem with one patient. Her legs kind of really swollen for a long time. Actually, now she's in my bi-monthly group. So I carried over this case, of course. She has been on Suboxone for a long time. We're talking about years. Now, well, her legs always swollen. And so we gave her Subutex. It sounds like her legs were getting better. So she took pictures, sent me snapshots, everything. So then when I tried to get Suboxone approved, and I also sent her to an allergist, sent her to family doctor, to basically to tell me, to give me proof like this is nothing else. This is just you cannot find any reason for the cause for this kind of edematous change. So, but anyways, so I had trouble getting it approved. On the other hand, I think if I'm the only provider, if I really think this leg swelling is kind of related to Suboxone, I might change to tablets. I might change to Zubsolv. But how long has this person been on Suboxone?
About 2 months, and the swelling started about the same time.
Okay. Is any so do you feel comfortable this is from Suboxone, or you're not very sure? Because I know it's very hard. Yeah,
I think it is. I think they've ruled out most of the other possible causes, and she does have Hep C. It's potentially due to that, but I think it's much more likely Suboxone, given the way it just onset with the Suboxone. And actually, she wasn't even trying to say that it was an allergy, or didn't even realize that it might be connected, and I'm the one that became concerned. So I don't think she's trying to play me for Subutex, but I always am afraid to put anyone on Subutex anyway.
Have you thought about hydrochlorothiazide?
Nah, if that works, I'll do that.
Yeah, my patient tried that. It did not really help. So that's, but I agree with Dr. Hirschler. That's something probably worth trying. So if we have to put her on Subutex, I guess we have to, right? Because if you feel like this is from Suboxone, and then let's see, if you put her on Subutex, she might, then the swelling will improve, then that's good enough, right? Yes.
In terms of, so Medicaid wants you to document that you're observing the side effects, right? And then will they then ask you to try the Suboxone tablets next?
Yeah, Suboxone tablets. Then usually we try Zubsolv as well.
Okay.
Yeah. Sometimes I try Bonneville, but.
Okay.
I would also recommend too that we've had with patients with swelling from Suboxone, if there's any chance for her to lower the dose, that also helps. You can keep them on Suboxone, and that might also help first.
Yeah, that might be.
Thank you so much.
That'd be very helpful. That could be.
Did that help? Got some plans?
That was really good help. Thanks.
Excellent. All right, guys. Well, we're at the end. I hope it was a great session for everybody. We'll be back in 2 weeks, just before the Thanksgiving holidays. We are meeting on that Monday, the 25th, and I will be sending out plenty of reminders. And everybody have a great day.
Thank you.
Thank you very much.
Bye.